Hello, everybody. My name is Heather Henry. I'm an entrepreneur, and we are going to consider today whether our health and care services need rehumanising. And in particular, because this is the Health Creation Academic Network, we are thinking about what this may mean for the way that we educate our health and care professionals. Our working definition of health creation is the enhancement in health and well-being that occurs when individuals and communities achieve a sense of purpose, hope, mastery and control over their lives and immediate environment. That definition by Hazel Stukeley of C2 Connecting Communities. And we are a movement around understanding and supporting the causes of wellness, which is complementary to the prevailing paradigm, which is pathogenesis, which is understanding and managing the causes of illness. And hasn't the pandemic highlighted this for us? Today we have Donna Hall with us, and together we're going to consider what is our future for the health and care workforce. What is it that they need to do differently to enable communities to flourish? And Donna is somebody, more than many others, who has turned public services on their heads, from delivering services to people in need to co-producing with communities. And she chairs New Local, the think tank, which sets out a case for a fundamental shift in how public services work. And their report, The Community Paradigm, which I pointed you towards in Eventbrite, makes an urgent case for the wholesale response to the twin trends of rising public demand and people's unmet appetite for more influence over their lives. Donna was the Chief Executive of Wigan Council for 8 years and was instrumental with others in developing the Wigan Deal, a new relationship with residents that delivered £160 million worth of savings and improved services and resident satisfaction. She also created another social contract while Chief Executive at Chorley Council called the Chorley Smile. And she's chair of the innovative national think tank New Local, which promotes a new community paradigm, is the chair of Bolton NHS Foundation Trust, where I was born, Donna. And she's also honorary professor of politics at the University of Manchester and is an integrated care systems advisor to NHS England. Welcome to Donna.
That's brilliant. Thanks very much, Heather. And what a great gathering of people that you got together here. I think it's fantastic, the work that you're doing, and so badly needed. So thank you very much for the invite today. If we can make it a very informal, relaxed session, if that's okay. I don't like formal lecture type things, and just if I can just speak from the heart, and then we can have a conversation and questions, and maybe work out what we could do together in the future, Heather, if that's okay with you.
Oh, more than okay. You heard it here and it's recorded.
Okay, that's brilliant. So shall I say a little bit about my background as well? You've mentioned so many things, which is brilliant, but just a bit of background to kind of so that people understand where I'm coming from in my heart, really, in my mind. So I was adopted as a child, and I think that experience of public services, it worked out, quite well for me. I ended up being adopted by fantastic family, working class family from Bolton. And went to university. They really loved me to bits, but at the same time met my birth mum, who had a horrific experience of public services, and actually listening and understanding the role that public services plays in kind of life and death choices about children in care, really kind of got me into thinking about a different type of public service offer that we need to construct, which is much gentler, much more focused on the strengths in families, and works in a very person and very centred and very human way. So my dad was a strong trade unionist and kind of, really encouraged me into education. And that's, I'm really passionate about opportunities for children and young people. So that's my kind of background. and how I got into this different way of thinking. I also, my first ever proper job was in Odsal in Salford, so you'll know it well. I used to work for Salford City Council, and I set up a job shop under the urban programme, so it shows how old I am. There was a job shop in the district, in the precinct in Odsal. And again, listening to people from Odsal, understanding the reality of their lives and the things that, you know, I started in the year that the job centre was burnt down on Trafford Road, you know, and listening to the frustrations and the feelings of communities in Odsal and the stigmatisation of those communities really kind of fired me up. So following that, I did lots of work in regeneration. You know, we managed to get £25 million worth of regeneration into Seedley and Langworthy, you know, quite a deprived part of Salford. And I watched us waste that money. I watched us just spend that money, set up a load of projects, build a load of buildings, and then disappear after 7 years when that money had gone. And we didn't make a lasting change in that area. And I don't think that was different in very many other areas of single regeneration budget. So it's all those experiences have kind of made me the way I am a bit, I suppose. So I think the starting point for me is that public services are unsustainable in their current form. They are broken, I think, beyond repair in their current state. That's the NHS, social care, local government and policing and criminal justice. Quite a controversial thing to say, but I disagree with some of my colleagues who think that what we really need is huge amounts of money to fix them. I do think they are underfunded, and you can see the impact that austerity's had on our figures in the northwest of England, and particularly Greater Manchester. I don't know if you all saw the Sir Michael Marmot's report, Build Back Fairer, a couple of weeks ago, and the impact on Greater Manchester. You were something like 4 times more likely to die of COVID if you live in Greater Manchester than the rest of England. And that's the impact of austerity, pure and simple. What he's told us would happen 10 years ago has actually happened. So, you know, I just don't think it's just about money. I think it's partly about the way that we work differently with communities, and we invest in the societal infrastructure, in the community infrastructure, as well as in building new hospitals, in asking for more beds, and in asking for additional funding for social care. I think we need to reinvent social care completely from the bottom up. I also chair a social enterprise that supports people with learning disabilities in Rochdale. So, you know, I see firsthand just the difference in commissioners across the north of England, and how some of them want to do things differently and how others kind of hide behind a service specification and don't really want to engage with a different way of doing things. So we have a lot to do. So a little bit about some of the stuff that we did in Wigan, Heather, if that's okay, because I know it does interest people if you don't already know about it. And I would really recommend, if you haven't already seen it, the King's Fund evaluation of the Wigan deal, which is probably the best evaluation I've seen. They came to live with us. They spent about a year in Wigan, and they used ethnography. So they listened to people, listened to local residents, listened to staff, listened to partners, and really got beneath the skin of what made it work. It wasn't perfect. Heather came to see us loads of times, and, you know, is a good friend of Wigan. And, you know, but basically what we didn't suddenly go to bed one night and woke up with this fantastic idea of the deal. It was iterative. It developed over time, and it was a team effort. And it was just as much the community telling us what we were getting wrong repeatedly that helped to shape it. And it's still going on now. I think I'm doing some work with Birmingham City Council at the moment. And what's fascinating is within the last 4 years, they've had 5 different chief executives of the council. And they've had 5 different strategies. That's in 4 years. So strategies for place should never be about the leaders. They should never be about the chief exec or the politician who happens to be in charge at that particular time. It's got to be about the place and the people. So that's what we tried to do with the deal. It started off with some work we did with a woman called Hilary Cottam. I'm sure, in fact, Hilary would be a great guest speaker for you, Heather, here at one of these sessions if you haven't already invited her. So Hilary is
know her. Give her a nudge.
I do know her, yeah. I know her very well. I describe her as a friend. Yeah, she's a really good friend. And she did some work back in 2011 now. She came to Wigan. So just about the time I came from Chorley to Wigan. And she started doing some work with her company at the time called Participle in a place called Worsley Mains. And we gave her a council house and said, and basically she scoped out a project where all public servants who worked with families, about 25 families whose children were deemed as being on the edge of being taken into social care. And we basically said, work out what we're doing wrong here, Hilary, with your team. Get public servants together and do an experiment and find out what is going wrong here. Because we're spending a huge amount of money every year, about between $250,000 and $500,000 per family. And what we were doing was just assessing them, repeatedly assessing them, waiting for them to tip into crisis, and then referring them onto another bit of the system without actually helping them, without building a relationship with them. And this was the police, criminal justice, social care, both children and adults, mental health, drug and alcohol services, the NHS benefits, anything, education, welfare, anything you could think of. And we were spending 80% of our time on the assessment process itself, where all our money was going, and 20% of our time as public servants on trying to help the family. So we learned very quickly during this year and a half of working with Hilary that we needed to change the way we did things, and we held on to that learning. What's interesting in Hilary's book, I don't know if you've read it, Radical Help, which has been printed and sold out all over the place, is that at the end she did 4 experiments. Each experiment cost £1 million, and one of them was the one in Wigan. And she basically, at the end of each chapter, which is, you see the outcomes that she's achieved, but at the end of every single chapter it says, and the following year, unfortunately, the commissioners decided not to recommission this work. So this can't be about projects. We know that commissioning needs a complete overhaul. It needs to be completely blended in with delivery, in my view. I've been in charge of a clinical commissioning group, and they're very distant from people, very distant from residents and from people using and accessing services. So, I think bringing them together into one team, as is being mooted in the integrated care system guidance, is definitely going to give us an inroad into trying to reshape things around people, around families. But it won't give us all the answers. I think the integrated care system work needs to, instead of looking up to NHS England for guidance, we need to look out to communities to try to think and look and analyse, as we did in Wigan, find out what we're doing wrong. But then not just have an experiment about changing it, just change everything in a place. And I think that's the uniqueness of what we tried in Wigan, Heather, was we did it as a team across a place consistently. And the King's Fund said it's the simplicity and clarity of purpose that differentiates it from other things that other people have done. And then the constancy of purpose. So we had politicians like Keith, who Heather, and Peter, and other politicians who really believed in it, and they wanted to try something different. Interestingly, they were Labour, so always been a Labour council, Wigan, but the Conservative group liked it as much as the Labour group, because it was about supporting people through a period of really horrible austerity to be the best they could be. We managed to freeze council tax as part of it as well, because we didn't want to pass the cost of austerity onto the resident. So that freezing of council tax meant an additional £500 per household in Band D property every year, because we wanted to, protect people, particularly people on fixed incomes, from the worst effects of austerity. The other thing that we did at the same time as working with Hilary was the work in schools with a company called Nesta, social enterprise called Nesta, and we did something called the Creative Councils Project, which was working mainly with people accessing social care. And again, some very similar findings there, that we were spending a huge amount of money, giving people what we thought they wanted, which was a day centre, or residential care, minibus, very formal respite provision. But it wasn't what they actually wanted, and it wasn't tapping into the things that they like to do, and their strengths and their passions, really. So the work we did with Nesta, the work we did with Hillary, plus the need to save a huge amount of money and the recognition that what we were doing was expensive and not very good, and achieving very poor outcomes was what led us. It was those three things really to create this new social contract between citizen and state, which is the deal. So the deal's really simple. It basically says our part on one side of the page, your part on the other. And the first bit is around recycling, us freezing council tax. We had one of the lowest levels of household waste recycling in the whole country at the time. So we really wanted to push recycling and get people to recognise the environmental as well as the cost implication of it. At the same time, we showed that we weren't perfect and said, tell us when we get it wrong. That was one part of the deal, because we're not perfect. And took quite a bit to persuade the politicians to accept that we weren't perfect and to tell people that and to apologise for when we got it wrong. At the same time, we were making all these cuts. We decided we were going to put money into the community and voluntary sector, about 13 million altogether over a 6-year period, and that we weren't going to commission it in a very top-down traditional way. We were going to ask people what they thought would be a good idea for their neighbourhood or a good idea to help address some of the issues that they've got around loneliness in a community or mental health for young people or lack of something to do in the evenings for young people, physical activity, programs for people who were led quite a sedentary lifestyle. So we had a growing number of people with dementia as well. So we set up something called the Rugby Memories Group, which we did with Wigan Warriors. And we used the assets. So we thought, what have we got in this town, in this place? We've got some brilliant people, some brilliant community groups, some great sporting assets, some great cultural assets. Let's try to tap into those, build on them, grow them, invest in them, believe in them, and let's try to see what happens there. We can't continue to do what we've been doing for all these years and just expect things to change. We've created a big state which isn't actually effective because it's not listening. It's stopped listening to people. So we did a lot of listening. So we structured listening around our workforce initially. So 6,000 people altogether working in the organisation, and we created something called Listening into Action, which is basically where myself, the leader, the cabinet, the management team would do structured listening to frontline teams every 2 weeks. So it was quite a big time commitment, but we'd spend half a day listening to them, and then not just going away and doing nothing about it, which I've been involved in the past, in other places I've worked. We would then come back and say at the next session what we'd heard and what we were going to do about it. So it was quite responsive and people really liked it. And initially it took a while to build up trust, but we did it every 2 weeks for 8 years. So people started to build a proper relationship with the leadership team, which hadn't been there before. It was quite a kind of command and control culture. We did the same with residents. So we did something called Have Your Say in local communities so that they could hear what the plans of the council were, but also tell us what we were getting wrong. And there was quite a lot we were getting wrong. But that openness, obviously pre-COVID, that openness of a big public meeting and being prepared to take the brickbats but also the applause when we got something right, it really opened up the elected members in a way they hadn't quite done before. We also worked with the NHS really intensively, and we created something called the Be Wigan Experience, which was about a workforce and organisational development interactive experience for everybody who worked in the place. So whether you were a midwife, a police officer, a health visitor, a doctor, a school teacher, you would go on the Be Wigan Experience. And it was about the values that we hold dear as public servants working in the place. And it was hosted by frontline staff. So you'd get somebody who emptied the bins hosting one of the sessions, along with a local GP who would talk about how we worked in, say, Tilsley to support people in a different way, how we would use risk stratification. I don't like that word, risk stratification, because it sounds very technical, but how we would identify people who are at risk of something happening, going wrong in their lives, and proactively work with them to stop it happening. So we did a piece of work with our CCG to analyse who was at risk of an unplanned hospital admission, and work intensively through the GP with the family to try to stop that happening. by thinking about, we didn't call it social prescribing. We had this thing called the community book, which everyone had access to, every social worker, GP, every public servant on their phone, and they could tell people what was happening in the local area, what community activity was happening. And we encouraged people to look at it themselves as well. We had integrated place-based teams, so 7 integrated place-based teams that worked at the neighbourhood level, that shared intelligence about individuals and families. So out of that cohort, a population of 323,000 in Wigan, around 4,000 people at risk of an unplanned hospital admission. In a year, there was a 30% reduction in unplanned hospital admission from that cohort, because we'd had a different conversation with them. We used anthropology quite a lot as well, which Heather knows about, a fantastic guy who I'm sure would love to come to your session and talk about what he does, a guy called Robin Farrell. So we first met Robin through the Nesta work, and he's a fantastic ethnographer, anthropologist, freelance guy. And he helped to design all of our different conversation toolkits for frontline staff. So instead of starting with the question, what's the matter with you? We start with the question, what matters to you? How can I help to create a good day for you every day? How can I work differently to help you unlock some of the things that you're really good at doing? So Robin was brilliant, and he's helped lots of other councils. He's helping Bury at the moment. He helped Manchester. He's great. And we helped him we worked intensively with him to really reprogram the way we thought about our role as public servants, not just to transact with an individual and process them as a unit of need, but to deeply listen, not to make judgments and assumptions that our neural synapse, I'm sure if there's doctors on the call, the neural synapse that we all make assumptions about people and put them into little boxes. He trained everyone to stop doing that and to deeply listen. And everyone went through that programme, everybody, whatever your job was in Wigan. So at the end of the 8 years, we saw a huge improvement in healthy life expectancy in the most deprived wards, and the wards where you were more likely to die sooner. So in some of those wards, we saw a 7-year improvement in healthy life expectancy for women, which was bucking the trend in the national trend, which is people are basically, for the first time ever in 40 years, starting to die sooner and to have less years of healthy life expectancy. Social care did a huge amount of transformation. So it really started in adult social care, some of this stuff. And Stuart Cowley, Keith Cunliffe did loads with the workforce to get them to really think differently. It was so successful. We just spread it across the organisation at scale, and people learned how to have different conversations at all levels, whatever their job was. We gave away lots of assets to the local community, so libraries, swimming pools, bowling clubs, a farm. We gave a farm to a community mental health recovery project. So they've got animals there, they've got people growing things, and it's absolutely amazing. If you've got time to go and see Green Slate Farm, it's brilliant. So a very, very different model and way of working. And I think I retired a couple of years ago now, but it's carrying on. So it's not about the individuals leading, it's about the place, and it's about the commitment of the partners to keep that going and keep that momentum going. I'm trying to spread, someone's just mentioned Birdsong. I love Birdsong. And what we did was the integrated place-based teams were Birdsong. We didn't actually use Brendan Martin, who's fantastic, but we adopted the principles and again rolled it out across the neighbourhood teams, self-managed teams. So yeah, and what I'm trying to do now through New Local is spread that way of working across the country. So we've got now councils, about 75 councils now are members of New Local up and down the country, even Wales and Scotland now, who want to create this different model of public services. And the community paradigm, again, I think, Heather, you've shared that with people in advance, but the community paradigm is, I think, the only choice you've got for public services. We can't keep creating this very risk-averse, very distant, very top-down model of public services that we've become accustomed to particularly in the last 20 years. We've lost something. We've lost community in all of this, and it's community that will save public services, and vice versa. We've got to work together and more creatively with the strengths we've got, which are our people. So I also chair Bolton NHS Foundation Trust, and we're doing some brilliant work there. We've got a fantastic chief executive who is really passionate about integrated care, and a very different kind of management team to any NHS management team I've ever worked with before. Very outward focused. We see ourselves as a community hospital and community services. And often some of the NHS organisations I've worked with in the past, it's almost like they could be anywhere in the country. They're like a hermetically sealed piece of, a production line that don't connect with their local community. And I think we've got some really deep thinking to do about how we run our hospitals and NHS trusts. I think we need to get much more voice of community onto our trust boards, and we need to really think about turning integrated care systems outwards to community, not just upwards to the NHS. So I hope that's okay, Heather. Hope I've talked for long enough and not too long.
That's perfect. I think if you've had half an eye on the chat, people are saying that they could listen to you all day. So as could I. As you know, I frequently contact and visit Wigan, and watch your work, and those are the people that you've mentioned, people close to my heart, as much as I can. So it's great that you've got some connections that I don't. I thought I knew some people, but you know way more than me. So that's going to be really great to get some of those people onto our network. So this is our opportunity now to ask Donna lots of questions. You can either put your hand up physically or electronically, or put some information in the chat, put your question in the chat. I want to, while I'm waiting to see what people come up with, I'm working with student nurses at the moment, Donna, and on leadership. I'm in contact with quite a lot of student nurses at the moment, and I probably want to ask you first, what have you learned about yourself as a leader through that process?
I think, that's a really good question, Heather. I think the single most important lesson I've learned is, and that's just not just at Wigan, but my whole working life, has been giving that freedom to innovate to frontline teams. Very much the Buurtzorg model is the single most important thing you can do as a chief executive. Making sure that people feel that they can do whatever is needed to help the individual or the family, or the local community, because people very often don't think they can. They think they're held back by system rules, and even though very senior people at chief exec level think that people can just do what they want and there's freedom, there's not actually. When you go into frontline teams, people are held back by things that stop them working together, by things that prevent them from building a proper relationship with a family and helping them have those asset-based conversations, strengths-based conversations, and they just process them because it's the safest thing to do. And I think, obviously, particularly prevalent at the moment in child protection and, in children's social care. So do you know Amy Overend, Heather? Have you come across Amy Overend? She used to work at Bolton NHS Foundation Trust. She now works for the Transformation Unit. She's got some great ideas around training student nurses. She's a nurse.
I think I'm in touch with her probably on Twitter. So yeah,
she would be another good speaker for you here. She's really, like yourself, inspirational nurse.
That's very kind of you to say. Yes. Wow, we're doing some connecting today. Michelle, you've got a question. Do you want to ask about commissioning?
Yeah, thanks, Donna. That was a really, really interesting presentation. Talk, however you want to describe it, was brilliant. Thank you. So I just wanted to ask, you said the commissioning needs a complete overhaul. My experience of commissioning is zero, but I'd just be interested to know what currently happens and what an overhaul would do, if that's okay.
Yeah, no problem, Michelle. So when I was chief exec of Wigan, they asked me to be the chief exec of the CCG as well. So to do the two, to try to, bring the two things together. And what I found was a completely different culture in the CCG. I don't know if there's anybody on the call from a CCG, and I really don't wish to be rude at all. I don't think it's people's fault. I think it's a structural issue. But basically, they are completely removed from patients and citizens. And I was working there. I've worked there for about a week, and I just thought something's a bit wrong with this place. I couldn't quite put my finger on it. And I was thinking, what does it? It just felt weird. And then I realised it was the phone never rang. So in the offices, no member of the public would ever contact a CCG, because if you had an issue, you would contact your NHS trust or your GP or your social worker or your district nurse. You would never contact the CCG. So I feel it's so removed from real life that it's kind of, and obviously they've been set up to be run by primary care. And I think it's great to have clinical involvement, but I think it's incredibly bureaucratic and slow. So I'll give you an example. We had some, we obviously had to do some really quite nimble work during the first few weeks of the first wave of COVID in Bolton, because we were really hard. We were right in the eye of the storm, as we have been throughout actually, because Bolton's a poor town basically, and we had to just do lots of things creatively, differently, and the CCG said to us, "But you haven't told us what you're doing. You haven't asked us whether you can do it." And we said, "Well, we've just done it because we've reorganised things." And so they basically went away, because everything's done through a service specification, and drew up a service specification for what we'd already done. So it's it's not got that. And I'm a big believer in co-production, in multidisciplinary teams working together with communities and coming up with really different solutions. And I just think I think clinical commissioning groups are almost like, commissioning is like buying something, and for me commissioning is about creating something. Commissioning should be about working in a generative space to think of new ideas, and I've never come across that in 5 years of working with CCGs ever. Not generative, very much command and control, stopping innovation actually in most cases. So I really don't want to be rude about people, and Lynn says I'm not being rude. Thanks Lynn. But we need a different way. There's so many potential, so much capacity now within CCGs, because they're coming into integrated care systems. Let's use that additional capacity. Let's grasp that opportunity to be bold and radical and do different things, not to write more service specifications.
Lynn, you've got a question about 75 councils, and I don't know what that is, so you'll have to explain.
Okay, sorry about that, Heather. Hello, everybody. It was about, I'm aware of the fantastic work that Donna and Wigan did and achieved. And Donna made reference to the 75 councils that are members of New Local. And of course, they'll be on a journey that's behind Wigan. But has there been a publication of where everyone's at? Because I think, it took 8 years, and it's a really long time to ensure that corporate approach is sustained. I think that's what the question is, Heather. Have I made sense?
Yeah, you're talking about how long stuff takes, and how the fast followers of Wigan Council are faring. How do you know what's going on? Is that it?
That's a great question, Lynn. Thank you. I think we tried to make it look easy and simple, but it actually wasn't. Behind the scenes, we had lots of tussles internally, to be honest, within the council. So the hardest bit to change was children's social care by a long way. They were worried by the deal. They thought it would affect their Ofsted score for safeguarding. It didn't actually. It actually boosted it. So we got good for Ofsted for safeguarding. So I think they were worried, and some people quite like the distance between children and families. They like that professional distance. We didn't think that professional distance was helping. We thought, when you build a trusted relationship with a family, you're going to get better outcomes all around. And you've got to support families to be the best that they can be. So some real tussles. In the end, we had to make some difficult decisions about leadership. and have some courageous conversations about what people chose to whether to stay or to go. And we supported them with dignity to leave, to go to a place where they had a different type of culture if they didn't like what we were doing. So we were quite clear on, this is what we're doing. You either stick with it and stay on board the ship, or you go somewhere else, and that sounds quite like I'm a horrible person, but we just felt the behaviours and the attitude started at the top. And if we wanted to empower frontline teams to work to help and support people in a different way, the leaders needed to model that behaviour as well. But it's hard. And what we're finding in New Local is there are some really brave people, almost like they're at the frontiers of making change happen within their organisations. They're not always at the top. Sometimes they're in the middle, sometimes they're quite low down, but they're really trying hard. And what they need, I always think you need a kind of rebel alliance within an organisation to make that change happen. If you're not getting change supported by the leaders, you need to surround yourself with people like that Lynn, who wants to make that change happen, and put pressure on from all different points of the system. We know, don't we, in our heart of hearts, that we can't carry on like we are. We can't continue to go through. We're going through winter now in summer, aren't we? That was happening already pre-COVID in Bolton. So I'm sure it's happening everywhere. We've got to think of a different model. I hope that's okay, Lynn.
So we're going to move on to Rebecca Myers now, and she's got a follow-up question about risk, because this is all about power and control and risk and all of those things that CCGs and integrated care systems and local authorities carry, isn't it? And it's about how you manage that, I think. Rebecca.
Thanks, Heather. Great speech, Donna. Fantastic work that you're doing. I suppose my question was about this idea of risk being a sort of temporal, contextual, relational concept. So actually, what do we think is risky? Who's defining it? And as Heather says, is the power. So I'm interested in how you flex the approach to make sure that you're allowing people to do this stuff, but also, particularly in health, which is my background, where there is risk, clinical risk, how you flex it in a way to manage those different demands.
That's a really brilliant question. And, I think the starting point for me is sometimes the riskiest thing is to either not do anything or to do what you've always done. And it's looking at kind of negative risk as well. But I completely know what you're saying with clinical risk. And obviously that's got to come first and foremost. Life, do no harm has got to be at the heart of what you're doing. But at the same time, I think for me, it's about how everyone is connected in the system around that person of who is at risk. And the risky factors are the lack of communication, the lack of understanding of mental health in a physical health context, the failure to see the support networks that people have in place and to tap into them, and the failure to think about everything else that's going on in that person's life as well. So there's a lot of pressure on clinicians, huge amounts of pressure. And I think we've got to jump in and help, and it's that team around the person, isn't it, that we've got to try to create across public services. We did a huge amount of workforce reform, which started in social care. Again, my own personal experience, I think Heather might have heard this before, but I remember when my mum sadly now passed away, but when she came out of hospital, she had 22 people came to see her on one day. 22 people came up the drive. Knocked on the door, didn't really know anything about the family or the support network she had in place. We're just there for one little bit of either health or social care, clinical need. That's where a lot of our resources going. We've got to think differently about how we galvanise that resource in a more flexible and joined up way.
Got a question from Alison Patterson here. Alison may want to follow this up, but she's basically saying, does Wigan CCG now work differently because of the work you've done?
I hope so. It's when I was retired, they brought in somebody from a CCG person, an NHS person to run it. I don't know whether that says I didn't do a very good job, but he's a great leader and very much working in collaboration with the council. I think it's about the type of leaders that we have that really want to work creatively. It's funny, again, I won't say where, but I'm working with an ICS where there are 2 councils within the ICS area. It's quite a big area. And they're both ICS lead officers in the councils have got public health in their remit and adult social care, but both of them do the job completely differently, based on their personality types. One of them is really partnership focused, wants to listen to communities, quite a humble person, but wanting to do bold things and really shake up what he does. The other one is very command and control, very protectionist, hates the integrated care system, sees it as an interference and wants to carry on doing his own thing. So, we can't have that, can we? We've got to get everybody at every level to think team around the person. And, it's not helping people in this mystery place, I won't say where it is, by having those two different approaches. You see delayed discharges of care very often are boiled down to the relationship that the COO has with the Director of Adult Social Care. Now that's just not right, is it? That's so hit and miss. That's like a postcode lottery, isn't it? So, everyone needs to have these skills. We need a different type of clinical and professional leader for the future.
I've just remembered who Amy Overend is. I've reached that age. She wrote a book with Brian Dolan on management and leadership for nurses. Yeah. That's why I know her name. Anyway, lots of talk in the chat about this idea of rebel alliances. In fact, rebel leadership and pirate leadership and all that sort of thing is very on trend at the moment. So I think probably the question that we're asking is, how do we join your rebel alliance, first of all? and how do you be a rebel safely? Because, I'm outside the NHS for a reason. I think the NHS has changed massively since I worked in it 10 years ago. But my ideas were disruptive in the extreme. But you managed to do it within the system. Tell us your secret.
I think it's Helen Bevan, isn't it, who says you've got to learn to rock the boat but stay in it. So I think the starting point is that compelling argument for, however much money we get from the Treasury in the NHS, the rising demand is going to kill us anyway. It's not about additional money, additional hospitals. There are loads. There are at least 5 brand new shiny hospitals in Greater Manchester. Amazing new buildings, but look at the premature death rates in Greater Manchester. It's not about the buildings. It's not about how wonderful the hospital is. It's about how the community functions. So I think starting with that, and then joining the dots around deprivation, understanding the life of, what it's really like what you do, Heather, in Salford with the Salford Dads. I think everyone should do work like that. Everyone needs to understand the reality of people's lives. And, very often people who set policies don't talk to real people. They don't talk to them and listen to them. So I think that's got to happen. And I think clinicians should be, not just clinicians, but every form of public service management should do some work in the local community as part of their job. I think that's got to happen. It
absolutely is. You feel more comfortable when you knock around with people who are like you. And it can be really uncomfortable. I go in the pubs in Salford and have been known to sit there for hours, and to places where, sometimes I feel a bit unsafe, and sit down and listen to folk. But I think that's what you've really got to do to understand the realities of people's lives, and you have to take the flak. And I've had walking sticks shaken at me, and in Stretford, and when I closed their clinic. But I think that's just what you've got to do. And to really, what comes across for me is that relationship building. And to build that relationship, and for me, it takes about 6 months because of the projectitis that I see. You seem like a nice lad. So we had another guy, and he, and this is the sort of conversation I get into. We've lost trust. We alienate communities by the way we work. Anyway, I'm going off on one. Telly, you have a question.
It's more an observation and possibly seeing the theme of what Donna have said. Firstly, I think your experience, Donna, I like to put it within the lived experience category, in that there's an assumption that lived experience is always about people who have been disadvantaged. So we therefore need to listen to them, rather than it's a mix of, the diversity of the lived experience. So for me, I think your experience will definitely be validated with, people within the community because of what you've done. And also, last night I was listening to the American organization, the National Academies of Science and Engineering and Medicine. They were the topic was aligning co-production of environmental knowledge with trust, justice, and equity, which is essentially how about what they're attempting to do in terms of working with First Nation people on the issue about environment. And two key points, which kind of confirms what you've just said, was the commissioning. It's about transactional, really, and it's about distancing. Whereas there's the two key points is that for moving from a transactional relationship, to a relational relationship, which is really what you've described, which is about co-production, because they're talking about the importance of the theme was about co-production, listening to the community. And what was beautiful was that they said listening as an act of love. So in that sense, I totally agree with you. It's about deep listening and actually letting the community be the leading, rather than you leading the show. So yeah, and I think for us, in terms of developing curriculum, which is the question, in terms of, because I teach health and social care, and so therefore I've just written a module which I'm going to be delivering next year, developing the concept of health creation as a way of working within the health and social care, but based in community development approach, community action approach. Yeah, so the question I'm now posing is that, given your description of giving assets to the community, perhaps we need to be talking about developing an infrastructure for health creation as our starting point.
Absolutely right. Yeah, thank you, Teller. That's a really good comment. Your work sounds fantastic. It sounds really just up my street. I think that's what we tried to do. We didn't call it a health creating infrastructure. I wish we had, actually. That's much better than it's really good description, but that's what we did. So our real driving force was improving healthy life expectancy. And, we spent 13 million on these bottom-up projects, and we looked at what wasn't there. We looked at what the community wanted, and then we just trusted them to do it. So I remember, do you know Barbara Nettleton, Heather? Have you met Barbara Nettleton from Sunshine House? So she was the biggest enemy of the council ever. She hated us because we would just go in, do stuff, and then go out. And we didn't have a relationship with her at all. So she came up with a fantastic idea to turn Sunshine House, a traditional day centre, into a brilliant community centre with like a cafe and fantastic social activities. And we just said, yeah, we trust you. Here's 140,000, just do it. And she was like, she couldn't believe it, because that never been, we'd micromanaged every penny she'd ever had. We'd spent more money on micromanagement than we had on actual giving them, on the actual money itself. And it was the nature of the relationship and the trust that changed. So 500 amazing community things like Sunshine House. And I remember councillors in the council chamber saying, you can't just give them the money, they'll run away with the money. You can't just, you can't trust them. they're all in poor areas, and they'll run off with the money. They'll go to Tenerife with the money and buy a villa or whatever. Anyway, of the 500, only two did run away with the money, but it wasn't a huge amount of money. But the other 498, the value we got for trusting them, the extra work, the extra commitment, the extra, just the relationship completely transformed to what we'd had before. So, I think it would be great if we could get people to think in that way, to embed those 6 Marmot principles, all the great work that you've done with Lord Nigel Crisp, Heather, on, building a health creating society. That's the philosophy. We've just done a call for evidence in New Local within the NHS and social care, and Nigel's evidence is brilliant, absolutely brilliant. And we're hoping that it's really going to influence the new Secretary of State. Fingers crossed, we'll see.
Okay, that's great. I need to look at that myself. So our punchline really, Donna, is, there's about 2,000, I think about the 2,000 student nurses at Salford at the moment, and the medical students and the social workers and those that will become housing officers and planners and chief executives of local authorities, etc. And it's about how we can influence the curriculum. Matt's talking about the situation in Northern Ireland, because of course this is a UK network and beyond, it seems to me. What is it? What are the lessons for the curriculum? If you were, the Nursing and Midwifery Council, who we love, we're going to really try and influence, what is it that we should be doing differently to educate our future public servants?
It's interesting. When we created the Wigan deal initially, we had a lot of interest from Denmark. And their Danish model of public services is they don't have chief executives, they have a chief anthropologist. And I think, honestly, the future of public services is embedded in anthropology, the study of human development. Why would you not have that at the heart of public services? I would think about inviting Robin to come along and maybe do some work with you. If you haven't got anthropology as one of the subjects in Salford, I don't know. But, it's how do we infect, as Keith often says, the NHS with wellness, but how do we think about the societal factors that only anthropology can help us point to? I think that's just, if you're looking for one thing, it's that in my book.
So you might want to read Gillian Tett's new book, Gillian Tett, Anthrotech.
Yes, I heard her. I heard her on Start the Week.
Yeah, she's been, for me, it's kind of nothing new in terms of the importance of using anthropology, social anthropology, to understand the nature of community, because historically anthropology is about wear out exotic communities, never to apply it because of its imperialistic history. Rather, this is if now. Okay, it's interesting. It's a bit like community development. What this community development has its imperialistic history, and it's kind of instead of a football coming home, it should be anthropology coming home.
Exactly. Yeah, I like that. Brilliant.
It's very interesting that Chris Dabbs, one of my mentors, an anthropologist. I think that's probably influenced me hugely, alongside a health visitor, Hazel, as most people know. But it strikes me as a nurse, as a young nurse, how I was taught to look for shock in people physically, and nowadays all I see is the shock of chronic trauma. And 3 or more adverse childhood events. That's what I learned to look for now, and I see it absolutely everywhere. And it's far more common than when I used to work as an intensive care nurse. We have time for one short question. If there's anybody out there, we will have Robin, I think, and have a focus on anthropology. Just put your hand up or type in the chat if you've got any questions. Judith.
Hi, it's just to really bring it back to like the academic side of things. How do you have any particular ideas, Donna, about how we really tackle this and start to embed this in education, so that we're actually growing practitioners for health and social care, those that might get involved in local government and policy, so that we can really get these strategies and processes embedded right alongside the passion. And how do we capture some of the people that, such as you've come across and involved in the work that you've done, how do we actually get them so embedded in the process?
That's a really good point. I mean, again, if you were to discuss this with Robin, what he did with us, with a woman called Tess Bill, I don't know if you've been on the DEAL training, Heather, but he basically gets all the people who work in public services to go out and have a ethnographic conversation in a local community. It makes you do it, and it's terrifying, but it really does change the way you think. Fundamentally changes the way you think forever about how you interact with people and power. So I would really encourage that with all students, that they go out into local communities in Salford and listen. I bet people in Salford think the university's gone mad, but you know, I really do think that's the way, is to get, because a lot of, again, I've got a friend who works at Manchester City Council, and she was just amazed at the fact that people have never been to Moss Side who work in the council. They don't know the city. They don't know, you know, the people and the pressures that they're under, and they're sat in a policy ivory tower just writing strategies without understanding the reality of life. So I think that deep listening, that listening as an act of love, as Tele said, in Salford or in Greater Manchester, would be the most powerful thing that you could do as a group of academics, I think.
Thank you so very, very much, Donna. We've come to our time. So just to explain to people where we're up to with the Health Creation Academic Network, I have set up a website at hcan.uk. The Twitter address is hcan with a load of numbers after it. Twitter, you really didn't do me any favors there. Donna, we'd like to take you up on your opportunity to be introduced to Amy, to Hilary, who I much admire, as you could probably tell, and many others. You know, we would like to stay close to New Local, because we would see ourselves as the sort of agitating arm of, you know, what you want to achieve through New Local, we want to achieve through education. We do focus on undergraduates of all shades, although we find that quite a lot of nurses gravitate to this, probably because of me, but all shades of any discipline, any community member, any policy advisor, any practitioner is welcome at our network. It is only by us coming together at that level that we can influence the curriculum and influence the regulators, who I think are sort of a microcosm of what you've suggested in terms of the way that public organisations have to change their power and control. The same way with the regulators do need to regulate, but it's about influencing their standards. We've got our fight at the moment around our special qualifications around public health and community nursing. That's our fight that you might want to have a look at. But until then, in September, we're hoping to have Malcolm Clark and Neil Baldwin. Neil Baldwin had a film of his life made called Marvellous, which was about his life as kit man at Stoke City, and his completely ignoring the disabilities, the learning disabilities that he faces in his life. Going beyond that, living a life of freedom. I'm hoping that we are going to have a little a watch party together to watch Marvellous. And so our next meeting will focus on, I haven't set a date yet with Malk, because Malcolm needs to be with Neil probably in the university, to Keele University, to do that. So we're going to do that. It's going to focus on, going beyond your limitations, not being limited by any so-called disabilities that you're labelled with. I don't even like using any of that. So do keep in touch. I've left you my email, there's the website, the Twitter account. I have a feeling that we'll see Donna again. Thank you for your energetic chat. The recording will come your way very shortly. And for now, I'll say bye.